Welcome everybody to today's COVID-19 Echo, hosted by United South and Eastern Tribes. This meeting is being recorded. Emily, do you have any housekeeping issues?
Yeah, we are offering continuing education credits, right?
Yeah.
Yeah. Okay, so I'm gonna share a link and I'll share it again towards the end of the hour. We are offering continuing medical and nursing education credits today. You have to complete the survey that I shared, and it'll also prompt you to fill out some evaluation questions. You can also get continuing education credits if you watch this recording later on. We are being recorded today. Please feel free to use the chat to ask questions throughout. We'll also have time after each presentation to ask questions out loud. And if everybody could go ahead and share who you are, where you're joining us from, we really like to keep track of what kind of reach we're getting on these. And that is all I have.
All right, great. Thank you, Emily. We have two great presentations today. We have Anna Garrett, who's doing the IHS, the COVID-19 area surveillance updates, and Imani Ransby, who's doing the presentation on COVID reinfection. So we can go ahead and get started with Anna.
Can you give me permission to share my screen, please? Thank you.
There you go.
All right, perfect. You guys can see that okay, hopefully?
Yes.
Okay, perfect. I cannot see you.
Sorry.
Right.
I was shaking my head.
Okay, perfect. So before we get into our EPI update, I did just want to quickly plug our universal screening program. So our universal screening program is a streamlined process within patient intake to identify anyone who enters a clinic with an illness that may require medical attention and intervention. So USET kind of objectives, we want to identify the clinic staff's perceived incidence and prevalence of HIV, STI, or STDs. We want to identify any potential barriers to patients seeking treatment or testing at any of the tribal nation clinics. For example, if it may be a social determinant of health or a transportation issue, anything like that. We also want to see if there are any obstacles to the health clinic staff in delivering testing or treatment. And some of these tribal nations we serve have incorporated this into their clinics on various clinical practices outside of HIV, STI, or STD, and did find it to be very beneficial. So why participate? So the goal of the program, we want to develop and implement innovative testing and healthcare engagement strategies focused on meeting the needs of high-risk individuals. So we're going to do this through two methods. One is a key informant interview in partnership with Southeast AIDS Education and Training Center, and then patient engagement surveys, which are online clickable surveys that we would hope to send to any staff members that the health director would be willing to allow that to go to. And then we would have a lunch that you would get if you wanted to participate. If you are interested in participating, you can contact Gabby, which is the infectious disease program manager, and her email is listed there, or you can reach out to me and I will put you in contact with her. And then if you are interested, you can also type that in the chat and we can get your information and send that to her as well, if that's easier. Also, I did want to plug, FEMA does have an upcoming Tribal Nation Training Week in 2023. It's March 11th through 18th. It's fully funded for tribal emergency responders, including round-trip airfare, meals, lodging, training, or any equipment required. We do have links here to all the different training courses with promo code to get it for free. You can sign up online or contact David Hall, but some of the courses they do have healthcare leadership for mass casualty incidents, isolation and quarantine for rural communities, or hospital emergency response training for mass casualty incidents, or even barrier precautions and controls for infectious diseases. So a lot of good opportunities here, just in case you may be interested. All right, and now on to the monthly COVID Epi update. So the sources that we use are still the same. We do utilize IHS Nashville Area Weekly COVID-19 Tracking Sheet. We utilize the CDC COVID-19 community levels, the CDC wastewater surveillance, the Health and Human Services, or the HHS Protect COVID-19 Data Hub, and for vaccines, we use the IHS COVID-19 dashboard or vaccine administration management system, and then the CDC COVID-19 data tracker. So these are the data sources we use to update these reports. So this is for the aggregate report. We have the variants of concern, which are still the Omicron variants, the Pango lineages. So B.1.1529, BA.1, BA.1.1, BA.2, BA.3, BA.4, and BA.5. We did have a decrease in the number of COVID positives in the IHS Nashville area, so we're down to 80, and we have a 7-day positivity rate of 13.7%. We had 274 hospitals contributing to the USET PERCSA. We had 1,321 hospitals contributing to the USET states total, and then 2,532 hospitals contributing to the US total. And just note that IHS is in the process of transitioning some sites to automated data exports for submitting COVID-19 testing data instead of continuing with manual data entry. So due to this change, information in the 7-day percent positivity and the total number of positive COVID-19 test results in the last week may not be reflective of the most recent week's data, as information may not be readily available. So for the community levels, this is what we were looking at the beginning of September. Here's where we are second week in October. You can see we have a lot more communities being reflective of the low community level, and then even some shifting from high to medium. So that is a promising trend. For the wastewater surveillance, this is updated as of 10/17, so just a few days ago. We do have quite a few states not having any data reported for this metric, but the ones that do, you can see they are still pretty high. This could be due to a lot of different factors. So the hospital admissions, this was at the beginning of September. You can see the USET PERCSA was 215. And now this week we are at 140.91. So we can see the COVID-19 hospital admissions are decreasing throughout the USET PERCSA United States and then the USET states as well. Additionally, for inpatient hospital bed utilization, this was the beginning of September, and this is October. So for the USET PERCSA in October, we're at 78.7%. For the USET states, we're at 73.6%. And for the United States total, we're at 78.5%. So for COVID-19 vaccines, this was the beginning of September, and then this is the beginning of October. So you can see we have had a slight increase for the COVID-19 vaccines for those reporting facilities in the IHS Nashville area, US, and then IHS as well. Additionally, for the COVID-19 vaccine data, the percentage of population fully vaccinated, This was from the beginning of September. You can see we're at a little over 53%. And then this month, we have increased just a little bit to about 55%. And you can see that's reflective of the other states as well, that increase. Then we have the percentage of the population fully vaccinated that have received another dose of the COVID-19 vaccine. This is from the beginning of September. You can see we're at 19.5%. And then in October, we're at 19.9%. So an increase for that as well. And you can see the other states are following the similar trends. So any resources for these data points, we have included links here. Additionally, we did want to cover the FDA amendments for the emergency use authorization for the bivalent boosters. So on October 12th, the FDA amended the EUA for Pfizer and Moderna vaccines, both of them authorizing a single dose bivalent booster to younger age groups. And CDC went ahead and recommended the same thing on October 12th as well for those 5 to 11 years old. The criteria, you do have to be at least 2 months after your primary vaccine series, which is the monovalent vaccine for Pfizer and Moderna. It also, like the bivalent booster for the older age groups, it includes the 2 different mRNA components of SARS-CoV-2, so the original strain, and then the BA.4 and BA.5 lineage for the Omicron variant. So these are the changes. So now Pfizer, the single dose bivalent booster, that is authorized for ages 5 and older. That was changed from 12 and older. The Moderna single dose bivalent COVID booster is now authorized for those ages 6 and older, and that was changed from those ages 18 and older. Additionally, the monovalent mRNA COVID-19 vaccine booster dose is no longer authorized for ages 5 and older, and that was changed from 12 and older. So now these younger age groups are eligible to get the bivalent booster as well for Pfizer and Moderna. Additionally, 2 days ago, the FDA did amend the EUA for the Novavax monovalent COVID-19 vaccine as well. Now it can be used as a booster dose in those aged 18 and up. The CDC followed this recommendation and agreed that we can use the monovalent booster in adults. The criteria, you do have to be 6 months after your completed primary series, and you are not supposed to have any other COVID-19 booster vaccine. And this is mainly for people who cannot or will not receive mRNA vaccines for whatever reason, be it an adverse event or anything like that. So I do have the references here for the expanded bivalent use, the original bivalent boosters, and then the Novavax. So now we do have these booster doses widely available to most age groups now. And then I can take any questions now, or you can drop them in the chat, or you can email us.
Great. Thank you for a wonderful presentation. Keep us up to date. Do we have any questions for Anna at this time? Hearing none, we can move on to Monty to talk about COVID reinfection.
Is everyone able to see my slides like on the full screen?
We see your slides not in presentation view.
Okay. How about now? Or is it still showing the same?
Still the same. You may have to unshare and then reshare.
Okay. Sorry about that. Technical difficulties. Okay. I'm going to turn my camera off to see if that helps because it's kind of running a little slow over here now. It's freezing up on me.
Do you want me to run the slides?
Can you hear me still?
Yes.
Okay.
Do you want me to run the slides?
I think it should be okay now that I've closed off my camera. Let me just try one last time. Sorry about that. Okay. How about now?
We see the presenter view. Just go to the 3 ellipses and do HUD presenter view.
Is it now? Okay.
That's-
Okay, maybe I'll have you share them for me, Brian, because I don't know why it's not doing it.
You're fine.
Thank you so much. I truly appreciate it.
No problem.
So I just wanted to spend some time today talking about COVID-19 reinfections or recurrent infections with COVID-19. I think this topic really started to make headlines during the Omicron waves this past year, as there were multiple reports of people getting COVID-19 again. Although we really still do not fully understand the science behind reinfections, but I do hope that I can provide some background on what information is currently available to us. That being said, I'm going to just go ahead and jump right into it. Brian, if you could please go to the next slide. So these are some objectives for today's content. By the end of the presentation, I do hope to briefly review the clinical and epidemiological features of COVID-19, define and outline the current case criteria for COVID-19 reinfections, assess scientific and epidemiological literature on COVID-19 reinfections, which would just involve taking a look at some articles and studies that are currently accessible to us, identify public health prevention measures that are used to combat COVID-19 reinfections, and lastly, highlight the current treatment options and recommendations for COVID-19 at this time. Next slide. So are we still in a pandemic? I'm sure this has crossed many people's minds, especially since recent claims were made that it was over. For me, I will tell you that the answer is yes, we are still in a pandemic, but the end does seem to be in sight. So that is reassuring. On the current slide, I do have some data from WHO that focuses on cases and deaths. And this is in Europe, the Americas, Western Pacific, Southeast Asia, Eastern Mediterranean, as well as Africa. And so with the top graph displayed, you're looking at the weekly COVID-19 cases, while the bottom features the weekly deaths. For both, you can see that all the geographic areas experienced a noticeable increase, both during this past summer, but this has since subsided. You'll also notice that in the top graph that Europe has been leading with cases, while in the bottom graph, the Americas have experienced the most deaths, it looks like. And all of this data is since January 2020. So we're looking at data from January 2020 all the way up to October 2022, this recent month. And so when looking at some of the data from this past Wednesday, we also see that the total global confirmed cases was at about 600 million, while the total global deaths was around 6 million. And then some other data from the 16th shows that the new weekly cases have decreased by 6% from the previous week. We were at about 2.9 million new cases for the reporting week of the 10th to the 16th of October. And then the new weekly deaths also decreased by 17% from the previous week, where we were at about 8,300 fatalities on the 16th. And so these are some promising changes, although the seasonality of COVID-19 has been in question. So we are still kind of in a wait and see situation. Although it is my hope that with the bivalent booster available, that the uptick we see maybe won't be as prominent as in the past. And we have seen that really since the introduction of the vaccination as well, just how these peaks are not as large. And I do want to also mention that WHO did meet this past Wednesday, and they did in fact state that we are still in a public health emergency of international concern. But as I mentioned, it has gotten a lot better when we start thinking of where we started and where we are now. But still, it is impacting multiple countries still. So I briefly wanted to take a look at the numbers here in the US as well as in the IHS area and Nashville region. I won't spend too much time, as Anna did a wonderful job of giving us all an update on that. But here in the US, we have seen COVID-19 hospitalization and death rates fall. And we also know that the vaccine specifically has helped prevent those adverse health outcomes as it lessens the severity of infection. But we are also learning that once you have gotten COVID-19, that does not mean that you won't get it again. And this is primarily due maybe to waning immunity and also the occurrence of variants that are able to evade the immune system safeguards. Anyways, on the left of this slide, we do have a map of the US with the COVID-19 7-day case rates per 100,000. And there was an increase of 32,211 new cases in the past week. This data is from the 19th, so I believe this past Wednesday, if I'm not mistaken. And we also see with this map on the left that in the United States, it seems that the areas that are being most heavily impacted at this time are in the Northeast and Western regions of the US, with that darker blue being depicted there. And so there has been an increase as of lately in those areas. On the right, we have a map that displays the IHS service areas and positive cases. So furthermore, when looking at the numbers for IHS and the Nashville area above, in the map that we see here, it looks like the Nashville area, we're ranging in about 15,000 to 28,000 positive cases as of the 15th. And our 7-day percent positivity rate for the Nashville area is a little bit higher than the IHS region as a whole, at around 9%. And you also have the positive test results listed there as well, if you want to reference that. Next slide, please. This next slide is just focused on variants in the United States. At this time, the main variant of concern is still Omicron, mostly BA.5 with BA.4.6 up next. And so with the picture on the left, you will also notice that as of the 15th, BQ.1.1 also seems to be circulating more. And this is something that public health officials are tracking continuously. Genomic sequencing is a great tool in tracking variants and reinfections, although there is somewhat of a lack of genomic data that has impacted our ability to estimate the number of reinfections in populations. But as you can see from the figure on the left, that dark greenish color would be the BQ.1.1 and how it's showing a little bit more than from the previous week from the 8th. So keeping an eye on that, but still at this time, BA.5 seems to be the dominant variant circulating. Next slide, please. So quickly, I am sure most are generally familiar with the signs and symptoms of COVID-19, but just as a review, SARS-CoV-2 is the virus that causes COVID-19. It is of the coronavirus family, which causes respiratory illness. We know that COVID-19 can spread through respiratory droplets when an infected person coughs, sneezes, or even talks, and symptoms may appear between 2 and 14 days after someone has been exposed to the virus. Just some basic clinical features that are associated with COVID-19: runny nose, headache, cough, fatigue, chills, fever, sore throat, shortness of breath, loss of taste, and loss of smell. And then as far as moderate to severe as far as moderate to severe illness goes, we know that there are some risk factors associated with that, as far as having underlying medical conditions and being in an older age group as well. Next slide, please. So looking at the case criteria for COVID-19 reinfections, case criteria is used to define COVID-19 cases, and as of last September, the case definition was updated to include language pertaining to COVID-19 reinfections, acknowledging that occurrence. I have a couple of links that you may find helpful as they outline information on the current case definition for COVID-19. And just an FYI, CSTE, or the Council of State and Territorial Epidemiologists, are the ones that decide and issue guidance on this criteria. So that is why I have those links listed there. And CDC also mentions on their COVID-19 reinfections website that they are working with CSTE continuously to try and collect data on this topic to better understand it, as there's still much to learn. So this is an excerpt from the CSTE case definition, the document that was linked on the last slide, and where COVID-19 reinfections are referenced. So from this, we can see that in one of 3 instances, a case can be described as new. So if the new positive result and past positive result are from different lineages, that would constitute a new infection. Or if a person had a positive result more than 90 days before the next infection, or if a person reported having COVID-19 before, but it was not counted, and now they meet the criteria. Next slide, please. So getting into some of the literature now, moving on to some of the research that has been done in this area. The first article that I wanted to share was a systematic review titled COVID-19 Reinfection, a rapid systematic review of case reports and case series. This did come out in 2021, and the updated criteria for the case criteria for reinfections was included based on recent studies, and this was one of those. It is peer-reviewed, and it referenced in the, and it does acknowledge that mutations can and have resulted in different variants of the virus, and also emphasizes the importance of tracking this information as we navigate the pandemic. Just some major takeaways. The case series did let us know that COVID-19 reinfection with different strains can occur, and some of these cases may result in severe illness with the second infections. This systematic review also found that there were 17 cases of genetically confirmed COVID-19 reinfection. There was one immunocompromised patient included in the study, and they experienced mild symptoms during the first infection, but during the second infection, that did result in death. For 68.8% of the cases included, they had similar severity of an illness, whereas 18.8% had worse symptoms and 12.5% had milder symptoms with the second infection. And then we also know that despite reaching herd immunity through either natural infection or through vaccination, that COVID-19 may, and we have seen has continued to circulate in populations. And then just really hitting on the last point of quantifying the true prevalence of COVID-19 reinfection may be challenging, again, because genomic data is not really available at this time for the majority of COVID-19 cases. So the next article that I wanted to touch on was an MMWR that came out in April of 2022. It covers data from June 2021 to February 2022. Just a few major takeaways for this one. Those with previous infection that received the COVID-19 vaccine had protection against subsequent COVID-19 infection that results in hospitalization. So pretty much saying if you had previously been infected with COVID-19 or had the vaccination, then you did not have severe outcomes resulting in hospitalization. As far as vaccine effectiveness against reinfection, again, leading to hospitalization during the Omicron waves specifically, that was about 35% after the second dose and 68% after having a booster dose. And also just emphasizing the importance here that all eligible should receive or stay up to date with COVID-19 vaccinations, including those that have been previously infected with the virus. This is a graph that I took out of this MMWR article specifically. It shows you the incident laboratory confirmed COVID-19 associated hospitalizations amongst immunologic cohorts, and then it's split up by vaccination status and previous diagnosis histories. And this data is from May 30th to November 13th of 2021. So this line graph, you can see that the solid blue line is the unvaccinated or no previous COVID-19 diagnosis, whereas the dotted line are individuals that have been vaccinated with no COVID-19 diagnosis. And you see that clearly the hazard rate and the risk of being hospitalized did increase greatly by being unvaccinated versus those who were vaccinated over time. So this next article was titled Reinfection in Patients with COVID-19, a Systematic Review. It is from 2022, so this year. Some more recent information. Just some key points regarding this article though. COVID-19 reinfection in those that previously recovered from infection is possible. So again, stating that individuals can become reinfected with the virus. It did include patients obtained from 50 different studies and looked at data from 2019 to 2021. They had a total of 118 cases that were found from their study. 37 of these patients were infected by different strains, while 9 were documented as being infected with the same strain at the time of their reinfection. And 9 patients did recover fully after their reinfection, whereas 7 patients also died. And then we had 5 that were hospitalized, and 33 and 9 patients were reported as being infected with the same strain. I believe that should be 9 patients were reported as being infected with the same strain. My apologies. And then we also found that for some of the patients, the immune response to the first infection, of course, did not provide full protection against another one. So again, emphasizing that COVID-19 reinfection can occur, and there is still much to be learned about this area or topic, although we do know that vaccinations, masking, and physical distancing have been valuable tools in mitigating COVID-19 in communities. So This next article is for early release. So it has not come out yet. And it does include a small number of cases, but also does pose a great question on whether the case definition for COVID-19 reinfections needs to be revised. This was a study that was done in France, and it also found that 3 patients among their study group were reinfected. For the first infection, they were infected with the Omicron BA.2, and then for their reinfection, they were infected with BA.5. The number of days between the primary infection and then reinfections with the virus and subvariants is listed here. So we do see that for patients infected with BA.1 or 2, the timing between the primary and secondary infections does range, with most of the cases being greater than 90 days, and 139 of the patients listed in the study group here. And so the study results do highlight that there may be a need for revision of COVID-19 reinfection definitions, as that 90-day period may not be as accurate as we once thought. And this is just a visual that was obtained from that article for early release. These are box and whisker plots, I believe. And so it shows you the Omicron variant. So for example, the first box and whisker plot that's listed there on the left shows that for initial infection, these individuals had BA.1, and then for their reinfection, they had BA.2. So those, and it shows you the number of people listed in that group. So 82. The X is the mean or average for the number of days. So for at least 82 of the patients included in this study, the time between reinfection and initial infection was 82 days. So that is less than the 90 days, again, that is described in the case definition. So really questioning whether or not we should revise that information. So wrapping up here a bit, I wanted to cover some COVID-19 public health prevention measures. We know that we always want to continue encouraging people to stay up to date with their vaccinations and boosters, as we know that they have been effective, again, in preventing moderate and severe illness, hospitalizations, and even death. It's also a wonderful idea to go ahead and create plans for outbreak preparedness in your community. As we know that different areas have seen increases at different times, especially here in the US. And then we want to practice COVID-19 mitigation efforts when appropriate. This would include our tried and trusty masking and physical distancing, washing your hands frequently, and all of those things that really help protect communities. And then I always think it's a great idea to highlight the importance of testing so that we can really get a better estimate of the prevalence of disease in populations, and supporting efforts to get genomic data as well so that we can track these variants and reinfections better. And lastly, to monitor the COVID-19 community levels, to know what you can do in your community to keep yourself safe as well as others, and look at the variants of the concerns circulating in the community, as well as the case and vaccination rates. Lastly, I just wanted to touch on some COVID-19 treatment recommendations. It's always a wonderful idea to assess the clinical appearance of the patient to best determine the route of treatment, and that would be regardless of whether they are presenting with an initial COVID-19 infection or a subsequent one. So really just looking at the clinical features that are being presented and going from there. as far as COVID-19 treatment that is available, the table on the right does include the monoclonal antibody and antiviral treatments that are available to us. I did want to mention just one thing with Paxlovid. Paxlovid is an antiviral treatment that we know can prevent severe health complications associated with COVID-19, especially in those that are older, specifically 65 and older. But it has been noted that Paxlovid may have some dangerous interactions with other medications, specifically with heart conditions, specifically medications for heart conditions and blood clots. Although we do also know that there is a list of medication interactions and guidance available. So the USET Tech does feel that it's timely to provide additional guidance. So I do want to just reiterate that in clinical settings, Paxlovid should be used appropriately to avoid medication interactions. And then to also consider if other treatments can be used if perhaps the person cannot get off of the medication that's causing the interaction at hand. Next slide. So these are just some resources that I gathered. Most of everything else that I covered is linked in the PowerPoint. There was another article from the Lancet if anyone's interested in looking at that regarding reinfections, and then just some general information on reinfections from CDC. I do want to just say that in some, again, there is still much research to be done to understand reinfections, immunity, and prognosis. We're still trying to understand protection that's given from subsequent infections and initial infection, and understanding viral clearance. And I'm thinking that it really is dependent on an individual's immune response and is also very likely to be multifactorial. So we cannot describe the risk of reinfection for the general population at this time, as more research still needs to be conducted. I do know that New York, they have a data dashboard that I believe is dedicated to reinfections, and I think also Hawaii as well. So some states are tracking this data, and it is available, although we still have a ways to go in estimating the prevalence of reinfections in populations. And I am happy to take any questions now. And if no questions, I would just be interested to ask the audience if they have seen a lot of reinfections in their community, and if so, have they done anything to combat that, as well as how things are going at this time with the COVID-19 pandemic and preventing disease within your community. And just also one additional update, I do want to announce that we will be transitioning this COVID-19 specific echo to an infectious disease echo in the new year, just to provide a greater range of content, including, monkeypox, influenza, HIV, AIDS, and HCV. So we will be doing that in due time. And I also just really want to thank everyone who has contributed to the COVID-19 public health response, and to say that, yes, we have been through this pandemic for 2+ years now, but we have made a lot of progress, and I'm thankful for everyone's help and their assistance. And I also just want to give a shout out to the USET Tech team as well for all of their hard work.
I have a question.
Yes.
The BQ 1.1, is that just a subvariant of the Omicron?
Yes.
Okay.
I believe.
No.
Do we have any questions for Amani or the team? just a reminder to fill out the survey that is in the chat, so you can get continuing education credits and give us feedback. It is very helpful for us. We do listen to those recommendations that you give us. Anybody have anything else? Bernice? No questions? Okay. Well, we can have a wonderful rest of the day. Thank you all.
Laugh out loud.
You always have questions. Okay. Well, y'all have a great day, and thank you all so much for coming.
Thanks, everyone.
Thanks, you guys.
Bye.
Bye.